السلام عليكم، بسم الله والحمد لله والصلاة والسلام على رسول الله. طبعا شاكر جدا الدعوة الكريمة وسعيد جدا لأني أشوف طبعا ما شاء الله سنة يتطور، وأكثر سعادة برفقة دكتور خالد ورفقة السيد العميد دكتور عمرو. طبعا نور ربنا يبارك ف يعني أنا شاكر جدا، وأنا ما بعرفش أتكلم كتير في مقدمات، بس أنا فعلا يعني I'm very much delighted. Thank you all. يعني I would like to go in the subject straight ahead, and these are my three elements that I'm going to talk about over the next 20 minutes, inshallah. First of all, basics and biomechanics. وأنا يعني one of the big fans of biomechanics and basic science. Second is clinical applications, and third is some of the recent trends. When we are confronted with a patient like this, this is an arthroscopic picture. This is the tibial plateau. Over there, the femoral condyle, and this is the lateral meniscus. This is the area of the posterior horn attached to the root of the lateral meniscus, and this is the area attached to the body. And as you can see here, there is a big gap between the two ends of the meniscus. What can we expect? This is definitely a complete radial tear of the lateral meniscus. What can we else expect to find some degenerative changes? As you can see over the tibial plateau, and some other rather deeper degenerative changes of the articular cartilage of the adjacent femoral condyle. So this is really a severe injury, complete radial tear with consequent degenerative changes of both femoral and tibial condyle articular cartilage in a 20-year-old footballer. So this is really a loss. How can we avoid this, as this is probably an irreparable tear? First of all, we should start with an overview of the general principles. We all know the healing response that we should expect from the menisci when we have a tear on the outer aspects of the meniscus, especially the lateral. We may expect some healing, good healing response if we repaired the tear in this area. We know also the rule of thirds, and this is very much basic and almost changing over age and over some other physiological factors, but generally it is rule of thirds. The peripheral third is supplied by blood coming from the capsule synovial membrane, as you all know, and we call the injuries over this area, the peripheral third, red injury, followed by red-white and white-white injury, which is not expected to heal whatever we do, as it is devoid of blood supply. We also know the function of the meniscus, which is extremely important to the function of the whole knee, especially in athletes. We know the types of stresses that are the menisci subjected to. We know the hook stress, at which the stress is distributed over the surface of the meniscus. We know some other kind of stress, which is the radial tensile stress, and we know also that we have two types of fibers. One of them are oriented vertically, and the other is oriented the other way around to make the meniscus more able to withstand almost all the different types of stresses which is subjected to, even if it is shear stress. We know the shock absorption function of the menisci, we know the load distribution function, and if we have the menisci intact for an athlete like a runner, for example, the meniscus is going to withstand horrible loads. The meniscus is weighted about few grams, and it tolerates the stresses of much more times the weight of its substance. This is one of the miracles of Allah subhanahu wa ta'ala in His creation of the human body. As long as we have intact menisci, we expect good function of the knee, we expect good performance of the athlete, otherwise we shouldn't expect. Why we shouldn't expect good function of the knee if we have some disturbance of the function of the meniscus? Let's go a little bit deeper in a couple of minutes. We all know the contact pressure, which equals the contact reaction force, or the joint reaction force divided by the surface area. We have many factors affecting this force, and we have another group of factors affecting the surface. However, the most important factor for the force is the magnitude, and whether it is sudden or cumulative. Sudden force will probably cause acute injuries, especially in athletes, as we all know, and the cumulative force will probably lead to degenerative type of injury, probably in older age groups. We know also that motion stability of the recipient surface is among the most important factors that affect the surface. I mean, if the surface is stable enough or not. However, the most important ever factor when we talk about the menisci and shock absorption function is the consistency of the recipient surface, the force absorption function. Cartilage, as we know, contain around 70 to 75% of its content water. And this is the greatest ever hydrostatic machine humankind had known. So if you have some disturbance of this, if we have disturbed biomechanics, if we don't have the shock absorption function working properly, we expect what we can see on the left-hand side. This is the normal forces and pressures, and this is the abnormal, and this is its measurements. You can find no contact pressure, but here the contact pressure is extremely high. Clinically, applying to this, we can find the edema of the proximal tibia. When we have an abnormally functioning or non-functioning meniscus, medial side, the bone marrow edema denotes this basic signs, denotes that the loads on the medial side are not tolerated and the meniscus is not functioning, and the baric surface is now the articular cartilage followed by the subponderal bone, which is not tolerating, which is not capable of having such kind of horrible forces, and pathology comes around at this moment. Second part of my talk is around the clinical applications of this few minutes of biomechanical talk. When we talk about meniscal injuries, we should classify them. What are the types we have of meniscal injuries? As we all know, we have the radial tear, we have the flat tear, we have the obliquely oriented tear, and we have the vertical tears. However, the worst ever type of meniscal tears we may have in an athlete is the radial type of tear, as it divides the meniscus into two separate pieces. And this enclosed space containing water, proteoglycans, collagen, and so on is now divided into two halves. So this brings down the function of the meniscus down to almost zero. So after this kind of injury, we don't have any function of the involved injured meniscus. And the pathomechanics following this is disturbed mechanics of the knee. We all know that the knee is having ligaments, cartilage, menisci, and everything in this knee is working for the king, which is the articular cartilage, to protect the articular cartilage. As well as we have intact meniscus, intact articular cartilage, we have good function meniscus, otherwise we don't. The disturbed meniscal injury, this type of injury would disturb the mechanics, and in the end of the day, we'll have an athlete who is not able to be back to sports probably with the same performance. And the other wing of pathomechanics is the mechanical overuse, and this is not our topic today. One of the very important papers I have read while preparing for this presentation is this paper, published by Andy Williams. I know him, he's a British guy, and he's dealing with the professional players of the British League, titled Evidence-Based Rationale for Treatments of Meniscal Lesions in Athletes. And in spite of not being a big fan of putting busy slides, but I found it very much beneficial to have some paragraphs of this very recent paper. Medial versus lateral meniscal tears. In athletes, lateral meniscectomies compared to medial have been shown to have increased post-operative fusions, missed game time, lower return to play rates, and more career shortening even than ACL injuries. When you have an injury on the lateral meniscus in an athlete who is probably professional, this is a very high red flag. This athlete should be promptly managed, otherwise he is going probably to retire. Even if he has an ACL injury, which is recent, probably the prognosis after managing ACL injuries is somewhat better than having a neglected, like we are going to see in a minute, neglected lateral meniscal injury, especially if this injury is radial. Starting with some clinical applications, if we have a patient like this one, meniscal injury, lateral meniscal injury, this is an incomplete radial tear. This is the femoral condyle, this is lateral meniscus, and the probe is going into the tear now. This is an incomplete lateral meniscus. Fortunately enough, the tear did not go into the periphery of the meniscus. They did not cut it into two halves, as we've been just talking a minute ago. So the treatment is just to debride the area, to make the end of the tear blunt, to guard against progression of the tear to the periphery and losing its function. So until here, we are still over the peaceful side, and this athlete might go back to sports. Okay, advancing clinical cases a bit more. If we have a peripheral tear of the lateral meniscus, like this one, this is the lateral meniscus on torso. It is not injured, but it is detached from the capsule posteriorly, as you can see now. The probe is going into the tear, and this is repairable, definitely, because in the regular location, and this is the all-inside device getting into the substance of the meniscus to insert 1 or 2 sutures promptly and with compression, and this probably will end with healing, hopefully, of the tear, and this athlete might go back to sports peacefully, probably within 4 months from the tear. A bit more, a radial tear of the lateral meniscus, another type, still the lateral meniscus, and actually this player, which is a message that I would like to conduct, this is a professional handball player who was diagnosed by us 4 months following the injury. And you can see here in the arthroscopic view, we have degenerative changes, probably type class 1 or 2 of the articular cartilage of the femoral condyle. So this is already affected. I've just been mentioning the king of the knee, the articular cartilage, which we all share in its protection. We have also on the tibia plateau, the articular cartilage on the tibia, as you can see, some affection as well. So this is a serious injury and was neglected for around 4 months. Someone who was not probably authorized to give him a decision, he tried with him to go conservatively, and that was the result. Complete radial tear, as you can see, of the lateral meniscus. He's a professional handball player, around 20-21 years old, in the national team. So it's probably a loss. And when he was admitted to the OR, that was the treatment, mixture of some debridement followed by repair of the radial tear. He took his time, and he's now back to sports, hopefully with the same performance. A bit more, if we have a tear like this on the lateral meniscus. This is a partially discoid lateral meniscus. We know discoid lateral meniscus, but this is a very extensive tear. White, and probably all the substance of the tear is disrupted and macerated, so there is no place for repair over there. And the treatment, we are obliged to do it, some partial meniscectomy, until we reach a stable and a smooth rim, as we can see now. However, this rim is not capable of performing well, and the knee function is going to be not like before. This patient is now getting to me probably every 1 or 2 months with effusion and pain and unrest knee, and this is the last sample of his aspiration probably a few days ago. So this is the post-lateral meniscectomy unrest, which we should all recognize and try to prevent. Going further, if we have a subtle, what we call subtle lateral meniscal injury. This is an MRI of a football player who had some very trivial injury, just a twisting injury while training. He had some pains, very mild swelling, but he is still capable of training. And this is another important point, a red flag when you have a patient who is persistently having pain on one of the sides of the knee. Even though he is training with no instability, do not hesitate to stop him from training and send him for medical assistance. This is his MRI. Even with MRI, the injury is not there. We cannot find it. We can hardly find an injury on the lateral meniscus, as you can see here and there. And this is the vertical cuts, and this is the rest of the cuts. You can't find it easily. The radiologist who is interested in sports gave us this impression, mild macerated appearance of the posterior lateral meniscus with a small complex tear involving meniscofemoral ligament attachment and joint effusion. But the patient is giving definite history of injury, and he's unrested and having some attacks of catching. We got him to OR with no reluctance, and this is what we found. A very big tear of the posterior cord of the lateral meniscus. I can't even get it till the end of the lens, as you can see. It's very subtle in the MRI, not very easy to diagnose, but this does not mean that this athlete is having nothing. He does have a serious injury, which we should discover. And this is the repair with all inside technique. Going back to Andy Williams' paper talking about radial tears of lateral meniscus decrease the contact area and increase contact pressures, I've been talking now, in the posterior lateral teeth. Although shorter than many longitudinal tears, the tear orientation means that the functionally most important longitudinal fibers of the meniscus are divided, thus leading to a devastating defunctioning of the lateral meniscus, akin to total or subtotal lateral meniscectomy. So radial tear is equal to total lateral meniscectomy, functionally. This is one of our patients, fortunately enough, to discover his injury earlier, and this is the middle part of the meniscus, this is the posterior cord, and this is the tear. This is an arthroscopic view, this is the femur, this is the tibia, around the video. So we can find some redness over there. Yes, the lateral meniscus is a bit more vascular, especially peripherally than the medial meniscus. And the rate of healing, fortunately enough, in the lateral meniscus is a little bit better than the medial meniscus. And this is what is the recent research telling us. When you have an injury of the lateral meniscus, repair it without hesitance. The medial meniscus is not probably doing the same. So this is the repair of the radial tear. This is a national player in the national team of athletics, gymnastics, sorry. This is the repair. He did some very good rehabilitation, and this is him 4 months later.
Wow.
Very good landing. Regarding the last few words about the rehabilitation from the surgical point of view, same paper, for meniscal repairs, weight bearing status and range of motion are determined by the type of meniscal tear. Repairs of radial tears and root tears are kept non-weight bearing. It's not shameful to treat your patient non-weight bearing in my mind. This is not a shame. This is the type of his injury. And this is the nature of his injury. This is what his injury dictates us to do. This is not shameful. And it's not some kind of courage to get your patient early weight bearing and he's having a radial tear or root tear with medial or lateral meniscus. So we should know the rules and follow and respect it. This is biology. This is not in my hand or in your hand. We should respect the biological response, the healing response, and go following them. Repairs of radial tears and root tears are kept on weight bearing, followed by 2 weeks of partial weight bearing. In coronal plane alignment is unfavorable than an offload brace, which we don't have, I think, in Egypt. Flexion causes posterior meniscal motion, especially over 60. Therefore, flexion is limited to 90 degrees for the first 4 weeks, following most meniscal repairs. For radial tears and root tears, most likely vertical flexion is limited to 60 for 4 weeks, followed by 2 weeks limited to 90. Last but not least, as flexion causes posterior femoral translation, especially laterally and on the medial side, a posterior shift of the joint contact area. Loaded flexion exercises are limited to maximum 60. Maximum flexion should be limited for our patients. I have seen my eyes when I repair one of the menisci, medial or lateral, while doing surgery, and then I flex it to the end to do some procedure on the femoral tine. For example, while doing ACL, I see that there my eyes is disrupting once again. I see the femoral condyle falling inside the tear, the vertical tear, and disrupting once more, and failing my sutures intraoperatively. So I expect this definitely what would happen if we allow the patient to do flexion, deep flexion. I'd like to thank you very much. And